And we're live.
Hello, I'm Melly Chancefeld, Managing Editor of Endodontic Practice US, a Medmark publication. Welcome to a live presentation and question and answer with Dr. Ryan Walsh. In our webinar today, we'll be discussing bioceramic sealers. Before we get started, I would like to invite our viewers to use the chat box on the right side of your screen to ask any questions, and your questions will be answered at the end of the session. Also associated with this presentation is a free CE quiz. At the end of the webinar, we will email all attendees the presentation replay along with the instructions on how to access the CE quiz. Now I'm pleased to introduce our guest for today. Dr. Ryan Walsh attended the University of Iowa, where he completed both his biology and dental degrees. He continued his education at Texas A&M University College of Dentistry, where he received his specialty certificate in endodontics and Master of Science in Oral Biology. Dr. Walsh is a board-certified diplomate of the American Board of Endodontics and an adjunct clinical professor at Texas A&M University College of Dentistry. He has written and published multiple articles in peer-reviewed journals and served as a key opinion leader for several companies in the dental industry. Dr. Walsh has lectured both nationally and internationally on bioceramic materials and maintains an active research interest in his field. Dr. Walsh, we turn the webinar over to you to learn more about our topic for today.
Well, great. Thank you. Thank you so much for the introduction, and thank you everybody else for joining us tonight. I'm sure some of you are getting ready for the Chicago midwinter, and those of us here in DFW are fighting the ice and snow to get ready to go up there. So I hope everybody's safe where you're at, and sit back, relax, and let's talk a little bit about bioceramics. And so our title tonight, I think, is incredibly appropriate. It's the bioceramic battle, David versus Goliath. How big Endo is seeking to cast doubt on our market disruptor, Avalon Biomed. And we find that in a lot of places in dentistry. We find it with composites, restoratives, surgical appliances, and things like that. So I want to expand on this just a little bit and give you some detail and some insight into the newer product on the market and talk about the market disruptor. But again, a little bit about myself, things that Mally already covered, so nothing new here. I do have to have a disclaimer saying that as a key opinion leader, I do receive honoraria for giving talks and discussions like this, but they're all based on my experiences. So the reason I like to give talks and webinars on these subjects is because this is how I practice. These are the materials I use. This is what I'm passionate about and feel that they play a very key role in dentistry. So learning objectives, we'll keep these fairly broad for this evening, and we'll kind of touch base on a few different things. So if you have any questions that I'm not touching, certainly please put that in the chat box. I want to be sure to address those all at the end. But overall, let's become familiar with modern bioceramic materials. What are they? What's present on the market? Of those on the market, what's similar? What's different? How are we going to be able to choose a material that best fits our clinical needs? Also talk about advantages to integrating bioceramic materials into our practices. They're relatively new in the scope of dentistry, and so some people are saying, well, I like what I do, it's successful, why would I make a change? Well, let's talk about that a little bit as well. And then most importantly, using those prior two objectives, I want you to be able to develop a system to quote unquote endo your way, or develop a model or a series of materials or a technique that allows you to effectively treat your endodontic cases on a routine and daily basis. So let's start with the basics. What are bioceramics? Well, bioceramics, mainly we think of zirconia, Lumina, dental porcelain, things like that. Things that are bioactive, bioinductive, inert, or biomimetic. I think a classic example that I like to use with my patients is that it's the coating of an artificial hip. It allows the body to heal onto this material rather than just allow it to be present. And we also have these in dental implants. Not only the restorative portion, but the actual implant itself. We have zirconia implants to allow the body to heal and integrate onto these rather than just coating metal with an hydroxyapatite type of layer. But really, for our focus tonight, we're going to focus on a different subset of bioceramics. And most importantly, I want to focus on bioactive bioceramics. And that's because as an endodontist, these are the things that I use the most. These are the things that I'm using in an everyday practice and that I want you to become familiar with. And here we're talking about MTA type tricalcium silicates, bioactive glasses, and hydroxyapatite itself, and or things that stimulate hydroxyapatite formation. So these are things that you'll find on the market. So these are bioceramics. They're things that you can purchase. They're things that I've handled clinically and tested and experimented with. And so these are some of the things that you should think of when you think of what are bioceramics on the market. So a few advantages of bioceramics. Let's kind of get that right out of the gate. I think that'll form a good foundation of everything we talk about as we move through tonight's program. So first, they're bioactive. It's not just plugging a hole. We're interacting with the body, which is what makes it a bioactive bioceramic. And so this particular little picture is one of our dog studies back in 2015-16. And here what it's showing is that these bioactive materials can induce mineralization. They can stimulate dentin formation, cementum formation, PDL, and osseous reformation. So these are fantastic materials that I really think need to become a part of everybody's daily endodontic armamentarium. Newer materials are the newer family, if you will, of bioceramic materials are non-staining. So again, this is from one of our studies. The product on the left has the bismuth oxide in it that I'm sure all of you have heard or been concerned about, that discolors teeth filled with MTA. Well, that might have been so. The newer version of materials contain zirconia or tantalite as their radiopacifier, which prevents them from discoloring over time and thus provides a stable color for the tooth structure itself. Next is antibacterial. We've been using calcium hydroxide in teeth for years, decades, and that's because we know the bacteria inside of our canals like an acidic environment. So how do we treat that? Well, we reverse the roles, make it very, very basic. The advantage of bioceramic materials or bioactive bioceramics is that in the hydration reaction while it's setting, it actually forms and releases calcium hydroxide. So you kind of get a time delayed dose of calcium hydroxide without necessarily having to put calcium hydroxide directly into the canal, or without really even having to introduce it into a material specifically, because it's just a byproduct of the reaction. And then last, again, part of one of the studies we did back in 2013 is they're dimensionally stable. Unlike so many things in dentistry where we have to think about shrinkage or C factors or different environments affecting bond strength and stability. Here bioceramics are dimensionally stable. As a matter of fact, many of them slightly expand, which is something that is again kind of new for endodontics and new for dentistry, is that you have a material that when you place it there may help to occupy a little bit more space, and the chance of it peeling away or pulling back from the tooth material interface is very, very low. So some huge advantages of bioceramics. So let's talk about the major players in the game. I'm sure all of you are familiar with composite resins, and it seems like every time I turn the corner, there's a new composite out, or a new resin, or a nanomer, or a bulk fill, or whatever you want to call it. It seems like there's a new one, and for me, it's really hard to keep track of. So I want to talk about the major players in the MTA-based bioactive sealers. Many of these manufacturers produce products for multiple people, and there's nothing wrong with that. As a matter of fact, that's relatively common in the dental industry in general. But I also want to make you aware of which products are tied to which manufacturers. So if you're purchasing these for your practice, you know how to compare apples to apples. And so the big one I think most of us have all heard of is innovative bioceramics, and maybe not in that exact title, but we all know Brasseler's BC Sealer, or BC Putty, the root repair. That's part of innovative bioceramics produced out of Canada. So iRoot, produced in Canada. The FKG is innovative bioceramics, but predominantly in the Middle East and Europe. And then Edge is also, the Edge Bioceramic Sealer is also part of that innovative bioceramics family of materials. Next, we have Avalon Biomed. That's the Neo family of products. So Neosealer Flow, Neo Putty, and Neo MTA. And then we have several others, including the relatively newly released Dentsply AH Plus bioceramic sealer. Then we have Septidon, Angelus, Vericom, MetaBiomed. And so we also have a subset of these called the resin-based bioactive sealers. I really don't want to spend much time on this tonight. They may come up just briefly, but that's not the main focus. These are some other things you've probably heard of as well, but I really want to spend the bulk of our time on the MTA-based, higher content bioactive products. And so, again, what do these materials look like? You've seen these before. These are all things that people purchase and have routinely in their practice. And you had heard me mention that the innovative bioceramics are produced in Canada. We have the Angelus products produced in Brazil. We have the AH Plus bioceramic sealer, I believe, produced in Korea. So far, you haven't heard me say anything about the United States, and that's because there is only one product that's produced, manufactured in the United States, and that's the Avalon Biomed products. They're manufactured, produced in Houston, Texas, about 4-hour drive from me here in Dallas. So I think that's interesting, and also I think shows that we know we're producing, or we know that we're purchasing a material that's following rigorous standards by the American government and the FDA. Not to say that other discriminate against other materials. However, when it's made here, we use it here. We know it has to follow strict criteria. So one question that I've been asked a lot is, what is this Neo product or Neo family of materials? Again, we're talking about the market disruptor versus big Endo. And really, is it anything new, or is it novel, or is it just kind of rebranding the same old thing? And I would say it's both truly novel, but yet based on foundations of predicate materials and predecessors that have decades of success. And so Dr. Carolyn Primus is the inventor of this material, and she was actually on the original patent for ProRoot MTA. So once that patent expired, she was able to take her knowledge from that, expand to improve clinical applications and handling properties and tooth discoloration and things like that. So, if we're talking about where's the research, is it truly new? Well, here's the research on ProRoot, and this is just such a small sampling of what's out there, but things I wanted to show you guys. Well, the next set here are studies done at the Texas A&M College of Dentistry since the early 2000s on Avalon Biomed products. So Avalon Biomed itself isn't new. It's just developing new products continuously. And so the products that you see on the market today, the Neo MTA2, Neosealer Flow, and Neo Putty, have a strong background of research. Now, because they weren't technically released to the market until 2019, we don't have a whole lot of retrospective case series or even prospective case series. However, there are some new and ongoing research studies I want you to all be aware of, because they're actively being pursued. One of them I have recently submitted for publication, talking about operations with Neo MTA. There's Dr. Wong, Dr. Jenny Wong's talking about external cervical resorption, and within that, we're talking about some resorption cases that were repaired with the Neo family of products, and I'll show you a few of those here later on. Dr. Gallegos is talking about vital pulp therapy with different types of bioceramic materials, including our Neo products. And then Dr. LaPure is comparing non-surgical root canals, just two different types of sealers, same practice, same doctors, and everything. So I think there's going to be some interesting research coming out. It's just not it's just not in the journals yet. So primary ingredients. Let's not talk just about the Avalon products. Let's talk about bioceramic, bioactive bioceramic products in general. The main ingredient you're going to hear time and time again is di and tricalcium silicate. That's medical grade Portland cement, bricks, if you will. This is what Dr. Torbinajad basically made to come to life 30 years ago. His family's history in masonry led him to believe that this may have some biological aspects as well. And so it's interesting that you take a concept of Portland cement and transition that into doing root canals. So I still marvel at the knowledge gap there. Next is calcium aluminate, and that's present in some but not all of the bioactive bioceramic materials. And we'll talk a little bit about that as well, because there's a little stigma around that. Next is an organic liquid, especially today with the pre-mixed materials. There's some sort of organic liquid, just depending viscosity-wise on how to deliver these to the teeth. And then last but not least, radiopacifier. And we talked about bismuth oxide discoloring teeth, but tantalum and zirconium as well. So all different types of radiopacifiers. And that is how the different manufacturers create their products is by varying the amount of these materials or excluding these materials from their product. And so the different balance and different ratios of all of these components determine the setting time, the working time, the acid stability, and all of the good things that we clinicians enjoy. So I do want to talk about Illumina because there is such a stigma around Illumina. It's kind of like, what's the big idea? You've been sneaking aluminum into my product? Well, no, not necessarily. Aluminum is one of the most abundant elements on the planet Earth. But these are just 4 examples of how aluminate has been used in dentistry for years and years. So first, let's start with ProRoot, developed back in the early 90s. Dr. Torbinijad's ProRoot has calcium aluminate in it. And so far, nobody has had any big questions or concerns about that because it's been clinically successful, and hundreds of studies have proven it to be clinically successful over long periods of time. The next place we find aluminate, we find that in porcelain fused metal crowns or dental porcelain in general, orthodontic brackets that are porcelain. Alumina is in so many dental products that we use already, and even our glass ionomer luting cement or pulp capping cement that has aluminate in it. And what I'm trying to say is that we're surrounded by aluminate and using it all the time with no adverse effects. So I think it's a bit of a stretch to claim that just because the Neo family of products made by Avalon contains aluminate makes them less bioactive or less biocompatible. I think that's a bit of a stretch and a farce. So let's further talk about that just a little bit. What does aluminate do? Here are just a couple examples of papers that I took these from. But aluminate's it's very good at allowing acid resistance. So what types of environments are we dealing with as endodontists and dentists dealing with root canal problems? We're dealing with an acidic environment. We're dealing with a pool of acidic tissue at the tips of these roots and in these canals. Why would we not want to incorporate a material that will allow our product to resist and to remain in place in these environments? It can decrease the setting time. It allows formation of hydroxyapatite on the surface. Again, bioactive. That's what we're looking for here. Biocompatible, and it increases the mechanical and compressive strength. So think of if we're placing this as a liner or a base or something like that, that's going to have direct occlusal load. Well, that could come into play. So aluminate has some advantages. And the aluminum hypothesis. I want to spend a couple minutes of this presentation talking about it and use our friends, the Mythbusters, to help me bust this myth, because there's been a stigma for more than 30 years that aluminum or aluminate being entered into the body can cause adverse effects, whether it's Alzheimer's or whether it's different cancers or whether it's autism or being on the spectrum. Regardless of what the claims are, there's been a lack of evidence to support that. And again, aluminum is a neurotoxin, but just like our mothers used to tell us, anything in abundance can be a toxin. So the simple fact that aluminum should be disregarded, because so are so many other thousands of compounds. And in addition, I really like this particular statement. They talk about it's irresponsible if editorial behavior is the suppression of the contrary evidence. And it goes on further to say that it's time that physicians and scientists face the fact that many innocent people have been hurt by their silence and act to make public aware of what is known on the topic. So, it's basically lying by omission. So these products were inadvertently tied to systemic disease, and there's been a failure to suppress that. So again, I wanted to provide these with you and provide a couple sources in case you were interested, but I think certainly in my mind, the aluminum hypothesis is busted. Let's now talk, since we're all clinicians, let's talk about the practical impact. I'm a full-time private practitioner. Overhead matters, especially in this day and age when there's supply chain shortages, when the cost of materials are going up, when the cost of doing a procedure goes up. So let's talk about our prices. On the far left, you can see I've listed the products. Some of the products come in different gram sizes, if you will. So for instance, Neosealer Flow, you can get a 2.2 gram syringe or a 4.4 gram. They also have a refill syringe, which I didn't include here. Just like Endosequence, they have several different types of materials as well. But I wanted to list the unit price next to it. because that's important. If you're buying these products, you should know what you're paying for and how they're being delivered. And so looking down at Edge Bioceramic Sealer, which again we know is in the same family produced by the innovative Bioceramics who produces Endo Sequence, it's the most expensive of all of these. Not that that's good, bad, or otherwise. It just is. We live in a capitalistic environment. So what I've done here is I've taken the price for the material and their recommended dose size and brought it out on the far right to uh, a price per dose. So in other words, when you treat a tooth with this product based on their dose size, here's what it costs you to treat a tooth. It will range anywhere from $8.50 to $3.25. So there's quite a wide range there. I also just recently got a flyer saying that Edge has a sale price down to $98.88, which great. Everybody loves a sale, but that still results in a price per dose of $6.42. So really what I'm trying to tell you guys is show me the money. Come on, Sherry, show me the money. Let's talk about this as a financial impact, and not that everything we have to do clinically should be the cheapest or vice versa should be the most expensive, but these are all things we need to take into account when we're figuring out how to endo our way and what's going to be our best procedure and material that's used in our offices. Interestingly, with sealers, it's not just the material itself, it's the delivery tip, it's the delivery vehicle. Because nearly every time you buy a bioceramic sealer, you get tips with it. And great, all the tips are different, or there's at least a handful of different types of tips. So I want to make you all aware of that as well. Avalon offers 3 different tip types: the flex flow, flow, and basic flex tip. I drew a special arrow to the little stopper on the flex flow tip because this tip overall is very similar to the Endo Sequence minimum waste tips and to Vista tips that you can buy. The one key difference here is that stopper. Uh, to me, I think that's an incredibly important piece of the puzzle here. At first, I didn't think it was that big of a deal at all. I would introduce my sealer into the coronal third, middle third. I don't really need to measure that. I can kind of get a ballpark. But now I'm intentionally trying to place my sealer 2 to 3 millimeters short from the radius or short from the estimated working length. So now if my canal is 20, I know I can measure that to 18 millimeters and put that into the canal and deliver it exactly at the place I'm looking. So then we move from that flexi tip to a single cannula and then to a larger plastic cannula. And so I've tried to get the prices for you here. A couple of these products were unavailable. I couldn't find them. If anybody has that information, I'd love for you to pass it along to me. That way I can include it for future presentations. But again, it all comes down to show me the money. Some of these tips are 75 cents and some of these tips are $1.50. That's a big variance. So let's choose the right tip for the right job. The photo here is a photo I took with my microscope after using BC Sealer and after using Neosealer Flow. Just compare those tips. The bottom tip is that flex flow with the stopper, and that has an 81% less waste than the tip right above it. I mean, 81%. That's huge. I think anybody here can see that the sealer left inside that top tip, regardless of what sealer's inside of it, you could still fill 2 or 3 or 4 canals, almost an entire tooth, with just the sealer that's now going to be tossed away. So I think the tip design in combination with the sealer is a really important consideration when you're developing your protocol and the materials that are going to be in your office. So let's compare apples to apples. Again, practical impact. We'll start with the flexi tips on the left side there. We're looking at one that's $1.25 and a one that's $1.75. Again, the top one from Avalon has that stopper on it. We're looking at the middle, kind of the larger plastic tips. We're looking at less than $1 to $1.13. And as you can see, the metal cannulas are 50 cents to $1.50. Well, why is the top row all cheaper? Well, it's interesting because all 3 of these are supplied by Avalon Biomed. So even if you don't use Avalon Sealer, you can buy their tips for less than you can from the other manufacturers. So if you're just stuck on using a certain sealer, hey, I'm not switching, great, keep doing that. You're doing Endo your way, but consider saving a little bit of finance here and purchasing the tips somewhere else. To me, that just makes logical sense. So let's break this down even further into a case-by-case basis. So I'm going to use Endo sequence high flow as my example because it's meant to use in warm temperatures. It can be used in single cone or in warm environments, and so can Neosealer flow. And so that's kind of why I picked this comparison. So if you use your sealer in your tip on a case basis, you're looking at a little over $10 per case. Let's just say you're an endodontist or general dentist who does 1,000 cases a year. Roughly, you're spending $10,000 on product. Now, I would say most of us probably do more than 1,000 cases, but 1,000 is a nice round number. I'm an endodontist. I don't do math, so bear with me. So let's just see what the comparison would be if we're using Neosealer flow. Again, what I think is a relatively fair comparison for product and use. And now we're looking at $5.23 a case, $52.30 a year. I mean, to me, if we can save $5,000 just switching materials to a material that has a higher potential content of the bioceramic material, has a tip that reduces the amount of waste, we're shooting ourselves in the foot if we're wasting all of this material. $5,000, and that's only if you do 1,000 cases. So if you do 2,000 cases, you're saving 10 grand right there, and you can distribute that then back to your staff, improvements in the office, and things of all sorts. So that's kind of my basic setup of the non-clinical stuff. Let's kind of get down to the basics, figure out where we're at. Let's talk a little bit of what everybody's heard about the materials, but now let's really get into cases. I mean, that's why I'm here. That's why you're here. are to see these products in action. How are they used? And so bioceramics in your practice, like we've talked about, they allow dentin formation, PDL formation, bone formation, and ultimately that's a recipe for success. And so that's how you develop a protocol to endo your way. So let's evaluate some of these cases a little bit more. So historical limitations of bioceramics. We've all been through using the powder liquid stuff. And, for many years, that's all we had. For 2 decades, maybe even a little bit longer, all we had were the self-mixed type of materials where you mix them into a relatively wet sand-like material, and then you use an MTA block or a MAP system to administer it. And I don't think there's any problem with this. As a matter of fact, I still think there's a lot of applications for this particular type of material that we can't get with some of our pre-mixed. And this is a case I just did recently where we have a blunderbuss open apex, and I think you'd be hard pressed to treat this with putty because the putty is going to stick on the walls and it's going to be hard to pack 18 or 20 millimeters down. You're going to be hard pressed to treat this with gutta percha unless you're going to do a custom cone and all of these other things. Here, I just packed 5 or 6 millimeters of Neo MTA Neo 2 in the apical portion and then backfilled it with the post and the core that the general dentist requested. So I think we have a nice fill that's going to stimulate osseous reformation. It's going to stimulate PDL reformation. So I think this is a really nice outcome. Because I just did this, I certainly don't have a follow-up, but I think this is an advantage of this type of bioceramic material. And so here's a case from a few years back that came to me. The root canal was done by a reputable endodontist in town. I just happened to be getting the second opinion. And I mean, for all intents and purposes, length, density, taper, that's a beautiful looking root canal. Unfortunately, we're seeing that furcation breakdown, which, that could be a crack or a fracture. Well, what it turned out to be was a strip perforation. Once I got inside and removed the gutta percha, I didn't find extra canals. I didn't find cracks or fractures, but you can see in the upper right image here, there's blood coming. So as soon as I got down to that coronal third, we started seeing heme come up. And so then I got everything cleaned out, and you can see the arrows encircling the perforation here. So for this case, we treated it. I was able to treat it very effectively with Neo MTA 2 because this is a material that is self-mixing. I can mix it for whatever need whatever procedure I need at the moment. So here, the distal canal is obturated using the Neo MTA 2 mixed with the washout gel to a sealer consistency. So I used it just as a sealer for the distal canal. For the mesial canal and the apical third, I used it as a sealer. But for that middle to coronal third, where the strip perforation was, I packed it and made it like a wet sand again. So I can use that same material, just flip the glass slab over and mix it with another liquid, and you have a whole new product. So here she is a few months later. And here she is a year later, and here she is 2 years later. Terrific healing there, not only apically, but also furcally. So I think anybody here can appreciate that intraradicular bone is soft and fragile and sometimes hard to heal, but this case turned out really nicely. And so again, just kind of an overview. It's a single material with varied consistencies. That's one of the things I like most about NeoMTA2 is the anti-washout gel, but then I can also mix it with lidocaine if I need to pack it. Now, granted, that's off-label use, but I think everybody here who's done the sand type of mixture has used lidocaine or some type of sterile water for that packing in the past. So again, all of these cases are from my private practice. If they're not specifically labeled, they're all my cases. If in this particular case, this is from my partner, Dr. Attar, and he did a case back in 2018. And what he did is he did a pulpotomy for this young person. Deep caries. The pulp was not necessarily inflamed such that we had to extirpate all the pulp. So he did a pulpotomy and stopped it at the canal orifice. And he used NeoMTA2 mixed with the anti-washout gel. And he made it into a putty, just rolled it into a little ball, gently placed it over the chamber floor and over the canal orifice, or both mesial and distal root, and then restored it with a bonded composite. So let's see, that was 2018. Here's a 6-month recall. You start to see the dentin bridge formation almost immediately adjacent to the bioceramic material, and you're seeing a little bit of root growth. And here, again, 6 months after that, you're seeing more root formation. Now here we are at 2 years, and here we are at 3-year recall. So that pulpotomy did exactly what the textbook tells us it should do. It stimulated reparative or tertiary dentin formation, allowed continued root development, and at that point, we know there was vital nerve tissue left because the root tips formed. So again, a fantastic case by my colleague using NeoMTA2. Now, I don't know about you guys. We joke with our general dentist that it must be something in the water here in Texas, but I see so much resorption. I don't know if it's because we're better at diagnosing it now. Our CTs are letting us see it more effectively. I just don't know. But I think this is becoming an epidemic. And given the timing, I hate to use the word pandemic, but certainly it's becoming an issue that we're seeing a lot in private practice. And it's frustrating because what options do we have to treat this? Do we give it cold steel and sunshine, extract the teeth? Unfortunately, I think many of them get extracted. And sometimes, especially like this middle CT on the bottom, we're looking here, there's really nothing we can do to restore that tooth. Do we treat them? What cases are going to be amenable to treatment? And if we do treat them, most of these are some type of Superman heroic cases anyway. But nonetheless, if we can develop protocols and we can use biocompatible and bioactive materials to treat these effectively and scientifically based, why would we not do that? So I want to walk down this path with you of this lower left case, which was a case I saw in private practice a few years ago. And the reason we have a CT to start with is, well, A, it's resorption. So I get CTs on all my resorption cases. But most importantly, this lady was very astute with her radiographic exposure numbers and knew that she didn't want 2 or 3 radiographs and a CT. She denied the radiographs and said, I only want the CT. So no problem. This is my best diagnostic image. And you can see on tooth number 8, she has severe resorption, severe cervical resorption. You can still see the predentin layer there, but you can see soft tissue ingrowth up underneath the cusp tip encroaching the pulp. You can see it's class 4 extending down into the root structure here, really just a hopeless tooth. And so I told her at this point, I said, look, I don't think the prognosis here is very good at all. And I'd rather have you invest your time, money, and effort by extracting it, and rather than having me repair it, and then 6 months down the road, you're extracting it to begin with. And so she left. And 2 weeks later, she came back and said, no, I understand the risks. I want you to treat this tooth. And so again, kind of walked through everything and said, as long as you are aware of what's going on, I'll walk down this path with you. So what I did is I used my System B and turned up the temperature pretty high to 600 C, and then used that as electrocautery for the palatal tissue that was encroaching inside the tooth structure. And because that had a nice matrix, if you will, I used Fuji 9, a true glass ionomer, to build up that lingual wall. So now I have a little bit of lingual tooth structure. And then I cleaned out as much resorption as I could. And I'm lying to myself if I were to tell you that I cleaned out all the resorption. You can even see the little white specks. They almost look like little dust or glitter. That's just part of that resorptive tissue. But I removed as much as I could. And then I used the Neo MTA2 and packed this entire tooth from apex up to the CEJ, or give or take, with Neo MTA. And I packed it all the way up, and then I capped it back off the lingual access with Fuji Tria, or excuse me, with Fuji 9, and that was in 2018. So I saw her back for a 6-month recall. Osseous levels still look good. I'm not seeing any periapical breakdown. And then here's fast forward to a multi-year recall. Here you're seeing the soft tissue is attached to the glass ionomer. You're seeing adequate alveolar heights. We're not seeing any deep cratering effects. We're not seeing any periapical pathosis. And equally as important, we're not seeing any progression of the resorption. So, we're talking a 1.5-year recall or so, and it's still healing. I'm still continuing to monitor her, although as well as I do, getting somebody to come back year after year can be challenging. But nonetheless, we're getting some nice healing there. And then lastly, talking about the self-mixed materials, let's talk about revascularization or regeneration. The JOE has an entire section dedicated to this. So let's talk about it for just a little bit. I was presented this case in 2016, an adolescent Asian female, and she presented with an abscess, as she described it, in the lower left. And what I thought of when I saw this was, that just doesn't add up. There has to be something else going on here. She hadn't had orthodontics yet. There has to be some type of anatomic abnormality. And sure enough, there was. This was my clinical photo of what I saw that day. And what we're seeing there is dens evaginatus, except we're seeing it after that occlusal most tubercle has broken off, and now it's exposed the pulp to the oral environment and leading to bacteria and pulp necrosis. So at that time, her mom specifically asked me if I would revascularize or regenerate this tooth. And I kind of talked with her about options, and I said, sure, I'd be happy to do that. And so this was my clinical result that day back in April of 2016. And yes, I think everybody here looking at it is thinking, boy, you got your MTA, or in this case, my Neo MTA, just a little bit lower than I had expected. That's just how it turned out clinically, fortunately or un. The good news here is that because it's Neo MTA, it's a non-staining, so this tooth isn't going to discolor over time, no matter where that's at. So even if she has some gum recession, you're not going to see any brown or black discoloration. I sealed it with composite, and then completely lost to recall until last year. And her mom came back because they had switched dentists, and the dentist asked or told them that something looked funny. You need to go back to the endodontist. And I was blown away with what I saw. We got maybe a little bit of root length, which looks great. I'm just kind of comparing it to the adjacents. But mostly we got root formation. We have the thickness of that root formation, and that looks great. The periodontal ligaments healed. The osseous tissue around it is healed. So to me, that just goes again to show these bioactive bioceramic materials are the real deal. They're here to stay. That's stimulating continued growth of a necrotic tooth. That's not even a pulpotomy where we're just trying to cap it and allow it to continue to grow. That tooth was necrotic. That stimulated tissue formation. So moving from the self-mixed to the pre-mixed, I call it an evolution or a revolution, because once those hit the market, I mean, all of us were on board and we're off to the races. The first one really to come out with any force was Brasseler's BC Sealer. And I think they did a nice job with their marketing, kind of hijacking the BC term, because whenever we think of bioceramic, we say BC. But these newer materials have easier handling. They're inherently anti-washout. And most importantly, they have a repeatable consistency, and they're easy to deliver. They either come through the sealer tip, or you can put it on a little spatula or Hollenbeck, whatever you'd like, and use that as an instrument to deliver the material. So again, the newer materials, rather than mixing them like wet sand, we're delivering them directly as is into the tooth. We're either injecting it into a canal, we're placing it on a spatula and putting it at the root tip, we're putting it on a plugger to do a perforation repair. They just allow us a whole host of opportunities that the previous materials did not. So interestingly, I came across this pretty recently as I was developing this lecture and talking about obturation trends. When I learned endodontics back at Iowa, it was lateral condensation. You put your O2 master cone in and you fill it with as many other cones as you can to get as much gutta percha in there as you can. There's thermofill, which was taught at Texas A&M where I did my residency. And so I had to learn a lot about that where you're trying to maximize the amount of gutta percha filling the space inside the canal. And then single cone, which when I was in residency not so long ago was, I wouldn't say thought down upon, but highly questioned. And rightfully so with the sealers that were available then. And interestingly, in 2009, only 3% of endodontists were using a single cone with bioceramic sealer. So an incredible minority of the folks. But fast forward 10 years or 11 years, now we're getting 60% of practitioners worldwide are using a bioceramic sealer, either with warm or cold techniques. But from 3% to 60, now granted it's not apples to apples, but 60% of people worldwide, that's huge. A lot of people have access to these materials because now there's a lot of materials to have access to. And we've also shifted from we've shifted the endodontic paradigm from a gutta percha centric obturation to a sealer centric. So here, because we have these bioactive materials, we don't need to fill the entire canal space with gutta percha and allow just a thin layer of sealer. Well, it's vice versa. I'd rather have as little gutta percha as I can inside there, using it just as a hydraulic delivery or carrier vehicle to get bioceramic sealers to flow. And so here's a comparison of Neo and Brasser's BC just in a plastic block that we've all used a million times. And you can see the flow into those lateral canals. That's what we're expecting, and that's what we want to encourage in natural teeth. So I got this from the AE's website, and I thought it was just an absolutely perfect demonstration of sealer-centric obturation. There's gutta percha cones placed in the mesial roots of mandibular molars and used to displace the sealer that's there to form a nice three-dimensional seal that has the maximum contact of the bioceramic material. That's what we want. We want the bioceramic material in contact with all the isthmus, with all the canal irregularities, with the lateral canals, because that's what's going to stimulate the body to heal these teeth. And so I wanted to share with you a few cases. Since Neosealer Flow's introduction in 2019, we've been exclusively using the Avalon Biomed products at our office and with terrific success. And so because, again, they haven't been out for that long, I don't have 5 or 10 year recalls on these, but I have several with good recalls that have great healing, and I'd like to show you those. And so this case was from just about a year ago, and I saw this guy, and immediately the first thing I think of is a vertical root fracture with that kind of J-shaped or cratering lesion starting from the osseous crest extending to the apex. I talk with the guy and discuss options, all that good stuff like we always do. And he said, I'd like to at least open the tooth and see if there's a fracture. No problem. I'd be happy to do that for you. Open the tooth. I was thankful there was no fracture found. So we obturated the tooth with gutta percha and Neosealer Flow. And take note of these little sealer puffs you see at the root tip. One looks a little larger on the DB and the other on the mesial buccal seems to be relatively well adapted. And so again, looking at that cratering bone loss, that's what I'm kind of following here as far as progress and success. And so here he is just a month or so ago, and we see that osseous defect that was before at the osseous crest has shrunk down significantly. We've gotten PDL reattachment, we've gotten osseous reformation there, and now the lesion is overall smaller. So again, I'm continuing to monitor this patient, certainly, but things are healing and healing well. And you see the sealer puff on the mesial buccal root. Most likely, as that's healing over time, the periodontal ligament will form around that small puff because it seems to be intimately associated with the tooth. The other puff was a little bit larger and was disconnected from the root. And so now as the body's healing, it's becoming into the center of the lesion and may over time actually become resorbed or just included in the body as a kind of an artifact at the apex. So again, talking about sealer-centric obturation. Here's a lower second molar I saw late last year. I have a very interesting dentist who refers to us frequently, where he doesn't like me to fully remove the decay because he wants to do that. And whether it's because he thinks he's more conservative in his decay removal, I couldn't tell you. So what I normally do is I'll remove circumpulpal decay, place a Fuji triage barrier over any decay so that I'm not introducing that into my canal system. and complete my root canal and temp it for him. And so that's why you'll see decay remaining here. I was not able to get patency. This is one of those cases where I'm sure it takes a sharp curve at the root tip. So I took my length film and I'm going to obturate to this level, and here's my outcome. What I want to emphasize to you is that this is 100% sealer obturation. I didn't include any gutta percha in this case. Because it was a confluent or a joining system, I placed my Neosealer flow tip 2 millimeters short of the apex in the distal canal, expressed the sealer and watched it flow up in all the other canals. And then I put a nice thick barrier of Fuji triage as an orifice barrier. So that way, when my dentist goes back to remove the temp and remove the caries, there's no risk of contaminating our root canal space here. But most importantly, look at the radiopacity. I think the radiopacity is excellent here. I think you'd be hard pressed had I not told you it was all sealer to say that there's no gutta percha there. So the radiopacity of Neosealer flow is fantastic and comparable to any of the other sealers that you're finding on the market. And a little bit more straightforward case, but nonetheless, one I was still concerned about root fractures and talking about things that are epidemic. Resorption and root fractures seem to be really prevalent these days. And so here, talked to the lady. She wanted to save the bridge. So I said, hey, I'm willing to jump in there and try it. And so we sealed it with Neosealer flow back in 2019. And this is, again, really similar to the plastic block case that we had talked about before. So I got her back on a 6-month recall. Yeah, things are looking good. Periodontal ligament's a little thicker. We're still seeing some of that reparative bone at the apex or in the periapical region. And here she is at a year, near complete healing. The bone looks fantastic. We're not having that thick layer of condensing osteitis around the apex. This is a great case, again, using Neosealer flow, showing how it's interacting and stimulating the body to heal native conformation tissue. This is a fun case I'd like to show with you guys because we have 2 teeth involved. First, she came to me in 2018. She needed me to treat tooth 15 because that was the source of her chief complaint. Although at that time I had told her that there's a lesion around 14 and we should probably treat that at some point. And she said, I totally understand, but we need to treat the chief complaint. So no problem. We treat the chief complaint. Treat number 15, and you can see here timestamp is 11 of 2018. And at that time I was using Endo sequence, BC Sealer. And I have used BC Sealer for thousands of cases prior to me switching to Neosealer flow. So I've used these other bioceramic materials with great success as well. There are some things with Neosealer flow that I will again try to emphasize for you that I think are improved upon some of the other materials, and not to discourage the others. There's just things that I think allow me to endo my way a little bit more effectively. So treated that tooth 15 with BC Sealer. I see her back for her recall, and she's ready for me to treat tooth number 14. So I treat tooth 14, find the MB2, and then see her back for a 1-year recall on that, and everything's healed there as well. But interestingly, between the two visits, or between the 2 treatments, well, I had Neosealer flow. And so this is just kind of an internal case control showing, hey, we have 2 molar teeth treated with different sealers, different bioceramic sealers, and we're both showing healing. So I think that's a fantastic result. Again, kind of an internal case control from our practice. Here's a more recent case. Again, 11 of 19, just when Neosealer flow was hitting the market. And we retreated this case. She's a city worker down here in Texas, a really nice lady. And we found our MB2, treated it, and we see her back in a year. And great, everything's healed at the apex. I mean, these aren't things that you haven't seen before. But they are things you probably haven't seen before using Neosealer flow. And that's why I want to bring that to your attention and show, hey, we're getting some neat or some good productive results from Neosealer flow. This I think it's my last case, maybe second to last case. This is a fun case. Any of us tooth nerds who get erratics are always kind of excited to see it because it's always a fun challenge and just kind of makes you smile for the day. So I treated this tooth. Length film, and you can see the obturation turned out very nice. We have 4 canals that are obturated well. They all look about the same, interestingly. But what I want to draw your attention to here is these canals are not the same. No one canal is the same. I used 2 different sealers, and with those 2 different sealers, I used 2 different obturation techniques within the same tooth, just to show the versatility of these materials. And so I used a hybrid warm vertical and these 2 canals, one with BC and one with Neosealer flow. And the others, I use single cones. And so again, this was a relatively recent case, so she's coming up for recall next month. But I wanted to show you that the radiopacity, the appearance of these cases with Neosealer flow are identical to other products on the market. Now, this is something really interesting because if any of you have used uh, AH plus Bioceramic or BC Sealer with warm obturation techniques, you found that it cakes. In other words, it desiccates. It kind of gets crumbly. You can even see it forming a little residue on the dentin. And sometimes, even with an alcohol pellet, I can't get that residue to go away. Well, I want to talk about heat stability here for just a moment. This was a study that was recently done by Avalon Biomed. And what they've done is they're showing you the hot plate put at 190. So right about 200 C, where the original warm vertical technique was described. And so going clockwise from the top left, we have Neosealer flow, BC sealer, AH plus bioceramic, and back on the bottom left, we have endosequence BC high flow. So watch what happens when these are introduced onto the to the heat pad. I want to first take your attention to the bottom right with Densplice AH plus. Watch as it's expressed onto the slab. You see it all of a sudden kind of warms up, kind of coagulates and forms this funny shape with little lobes and turns over. Next, on the bottom left with the BC high flow, you see all these small porosities developing. That's the organic liquid essentially boiling out of this material. And that's the claim there is it has a liquid that can more readily handle the high temperatures. And if you look at the upper right, you see this BC sealer starting to turn brown. I don't think we want to see our sealers turn brown. And then on the upper left, we have Neosealer flow, and it's still a sealer consistency. That has excellent heat tolerance. We're not seeing any of the bubbles come from the liquid. We're not seeing any color discoloration. So I'll play that for you again, just so that you can see all of these if it was too much for the first go around. Again, watch the little worm form on the bottom right. And all the porosities develop. And all the while, we're looking at Neosealer flow, and it looks nearly identical to when it was placed on the slab. So, thus kind of confirming the fact we can use Neosealer flow for a cold technique, sure, but we can easily use it for a warm technique as well without having any concern of its stability. Now, next is going to be the same test, just using 3 different materials. Here we're using, in the upper right, Diaroot, then we're using Edge Endo, and then in the bottom left, we're using BioC from Angeles. So exact same type of study. First, look at the upper right. Watch what happens when that Diaroot sealer goes onto the heat pad. I think you'll be amazed. It's immediately boiling. That organic liquid is nearly gone. Now, there's still some remnants of it there, as you'll see in just a moment. But look at the other 2 as well on the bottom, starting to maybe turn a little bit of color, starting to look like maybe they're hardening up. And that's the same video of Neosealer flow in the upper left. I kept that for you guys. Look at Edge Endo on the bottom right. It's turning brown again. But that's not surprising because it's the same product as, it's the same innovative bioceramic products as BC Sealer. So you're getting a similar result. This was just left on a hot plate a little longer, so it got a little darker. So why is heat resistance important? Well, anybody who's been doing root canals knows that sometimes you have to use multiple techniques in a case. And some people are true warm technique people, that they use warm technique in every case, it doesn't matter. Others, single cone every case. For me, I'm kind of a combination guy for the broad distals of lower molars, for a broad palatal. I may use a warm technique just so I can get nice density and then backfill it and then single cone everything else. But why is heat resistance important? Let's go to our good friend Steve Harvey, and the survey says that if you're using warm techniques, there's no desiccation or caking. So that's why heat stability is important, and you don't need to reapply a sealer because what you had there is all dried out. In cold techniques, you don't have to worry about the cleanup in the chamber. If you heat it and burn it off just at the orifice like you do with the single cone, well, some sealers, namely, in my opinion, Brasseler BC sealer, creates this chalky appearance of the dentin, and that's just some of the material desiccating into it. But if you're using a combination techniques here, and you're using Neosealer flow, well, you don't have to go any further. Use the same sealer for all your warm and cold techniques. You fill all the canals and seal them all. So to me, that it makes most sense because I don't have to change sealers. I don't have to change techniques. I do the same obturation regardless of what each specific canal looks like inside of a tooth. So let's move on from root canals just a little bit, root canal treatments to some other applications here, and talk about an apico, right? So this is again my study was published 2018. The study was conducted in 15 and 16 on dogs. And so as you can see from the radiographs on the left, we treated these dog teeth with conventional root canal in the mesial root. We packed the entire distal root with a bioceramic material. In this case, we were comparing NeoMTA and Quickset, which was a prototype material. And then we did an apico on the teeth and resected them. I did not do a retrofill. I literally just prepared out an osteotomy and resected the root. And then these are the healing that you see 6 months down the road in the bottom radiograph. And again, what I showed at the very beginning was that immediately adjacent to the NeoMTA, where the arrow's pointing, you have cementum forming. And that happened on many of our cases. Not all the way across, but the simple fact that at 6 months, we're seeing cementum formation is really encouraging. We're seeing complete PDL formation, and the alveolar bone adjacent is of normal type. So that's a beautiful heal. Now that's in a dog. I totally get that. So hey Ryan, move on. Let's see what it looks like in a human. Well, here we go. Again, this is kind of a classic endodontist case. Maxillary first molar, lesions around the roots, 3 canals filled. Well, we have an MB2. So no problem. I treated this case back in 2018. Well, 6 months later, she came back saying, hey, it's still not feeling right. I'm still having some pressure sensitivity. Well, sure enough, the lesion had gotten larger. So we took a CT just to get our surgical measurements, make sure what we were seeing, what we thought we were seeing in 3D. And so we completed her apico. And I used NeoPutty at this time. And so here's our 3 little retros, our 2 resections and 3 retros. And this was 2019. And after that, came back as a periapical granuloma for any of those, for any of you interested. And then she was completely lost to recall. I didn't see her for years. I couldn't get a hold of her. She let it go to voicemail. We all know that. I was hoping geographic success. Maybe she had moved and my root canal was doing just fine. I hadn't heard from her. But then she randomly came back for another tooth, and I was able to get my recalls on this. So here's 3 years later. PAs look great. But I had a CT before, so let's make a CT now and compare them. And beautiful apical healing. You can see it appears the ligament space is across the apical portion of that root, adjacent to the neoputty. You have great osseous reformation. We're not seeing any periapical pathology. So again, bioactive bioceramic materials are really where our specialty is trending and really where we're heading and stimulating healing processes. One more thing. One thing I really like about Neosealer flow is that I've talked about the residue that's left behind with some other sealers when you heat it. Well, Neosealer flow doesn't do that. In the chamber, once I'm done, if my chamber is full of Neosealer flow because it extruded out of the canals, you can wash it out of your chamber with water, with your air water syringe, and it washes out of the chamber. If you were to check down inside your canals, you can still see a nice ring of white material around your canal. So you're not washing out down past the chamber, but you're washing out all that material from the chamber and you have nice clean dentin. Conversely, I used to have to take alcohol and scrub my BC to try to get most of it out. And even then I would still see this white hue, and sometimes even after etching. But why is this important? Well, it's important because Hirsch with Dr. Kirkpatrick down in Houston did a study showing that composite to dentin bonding is 26 megapascals. But if you try to bond it to a bioceramic, you're dropping to a fraction of that. Now, granted, they were bonding directly over bioceramics, but you have to take that into some consideration that if your dentin is impregnated with a lot of bioceramic, you're not going to be getting as good of bond as you had before. And after listening to Dr. Ann Koch's lecture on the endo-pros relationship, she says the restoration starts at the apex. And I think we need to be good stewards of the restorative perspective that, yeah, we're root canal experts. We can do root canals, but we also need to set up for what's after the root canal. And in that case, that's the restoration. So if I'm placing a buildup, I would really like for that to either be air abraded or etched, or in this case, you can just wash the Neosealer flow out of the chamber, and now I have a nice clean starting place to bond my restoration in. So that's how I endo our way, or that's how my practice endos our way. We use Neosealer Flow, Neo Putty, Neo MTA2 because it's one family of materials that I can use in a variety of ways, whether it's resorption, perf repair, apico, sealer, pulpotomy. It's just there for all of these reasons, and it's easy to have. I only have to have 3 products. So the Neo family of products, they are actually formulated with more bioactive cement than other bioceramic sealers. So they have more of the bioactive product in them. They're more cost effective, not only the syringe material, but the tip itself. So the cost per case is more cost effective than most any other bioceramic on the market. The multiple products, the 3 products you see here, will allow me to treat every endo case I ever see. It's got similar flow, and you saw similar radiopacity, and it's got the easiest cleanup that I've seen with any of the bioceramic sealers, and I've used a lot of them. So that's how I endo my way. I use the Neo family of materials. So a recap of our objectives here today. There's a lot of bioceramic materials on the market, and all have pros and they have cons. This one's better for this or this one's better for that, presumably. But there's also common misconceptions that aluminate is not bad. Bismuth oxide does discolor, so you should look for a product that doesn't contain that if you're concerned with tooth discoloration. Talking specifically about the Wild West and New Frontier with the Neo family of products, they're not the Wild West. They're built on a solid foundation of research that's moving these materials forward. We are developing the research as time goes on to show how successful these materials are. And then now there's pre-mixed sealer putties and self-mixed materials that are becoming the new wave of endodontic revolution. Using bioceramics in practice, again, sealer-centric versus gutta-percha-centric, and using bioceramic sealers as a sealer-centric obturation technique. Cost of material, at the end of the day, it does come down to finances, and we need to keep our practices running. We need to provide our treatment at a fair cost to our patients. And I want you to have a product that you feel best fits your intended application. And so my question to you is, are you using a bioceramic or a family of materials that allows you to provide the best care you can for your patients? I am. I feel like I'm using material that I can best provide treatment for my patients, no matter what walks through the door, whether it's an apexification, whether it's a root and surgery. I feel that the Avalon Biomed products really provide me that level of comfort when it comes to the endodontic care for my patients. So with that, I want to thank you all for your time. I want to thank Avalon Biomed for allowing me to give this talk. If you need to get in touch with me, please feel free. Again, my name's Ryan Walsh, and you can find me on Gmail there. Don't hesitate to send me an email if you have questions, concerns, or if you have anything else to add. I'd love to hear from that as well. We're all here to learn from each other.
Thank you, Dr. Walsh. There are some questions coming in, but before I get to those, I'd like to, again, invite our viewers to use the chat box on the right side of your screen to ask any questions that you might have. I do have some questions. How long have you been using the Neo family of products yourself?
Personally, I've been using them for over a decade, coming up on 12 years now. So I started with Avalon when it was a very small company, doing some of the basic research. You saw that dog study, doing some of the basic research behind it, and then I've kind of stayed in touch with them and have been helping them and learning from them and with them as these products grow. So I've been using them for over 10 years now, and exclusively in my private practice for over 2 years since the Neosealer Flow and Neo Putty have launched.
Okay. Somebody said, is it hard to deliver BC Sealer with Avalon tips? I find that I have to use extra force.
Good question. Probably so, because in my experience, BC Sealer's more viscous, so it's a little thicker than is Avalon, than is the Neosealer product. So yeah, if you're trying to put it through the same small diameter cannula, yeah, I think you're probably going to have to apply more force with BC products. But using the Avalon with any of the 3 tips or cannulas that it comes with, I have no problem and actually use very, very minimal force when I'm using that flex flow tip.
Is Avalon available in Canada? That's a good question.
Oh, that is a good question. I will have to get back to you on that. I want to say yes, or that we could get it to you, but on the same token, I certainly don't want to overstep my bounds. I'll have to talk to I'll have to talk to Mark Binford, the president of the company, and see if that's available in that capacity.
Okay. Okay. Can you just summarize the key features of Neo MTA that distinguish it from the others just one more time?
Sure. Yeah. The things I like about it are it's cost effective. One, I think that's an obvious thing for anybody who's in private practice. It's cost effective. It's easy to use. It has easy cleanup. It has great radio opacity, and I can use that one family of materials for all of my root canal needs, whether it's warm or cold techniques. It really doesn't matter. It's a sealer that's really robust and can handle a lot of different case types.
Okay. Can I preheat BC sealer to make it easy to be delivered?
Can you preheat BC sealer to make it easy to deliver?
Yes.
Is that the question?
Yes.
Oh,
Can I BC sealer to make it easier to be delivered?
got it. I do not know the answer to that question. I don't know if you could heat it up and adjust the viscosity. Um, I don't know, and I don't know if you could, what the temperature range would be to allow it to flow better. And honestly, when I'm using BC with heat, it concerns me a little bit. But again, we're talking obturation versus we're talking rather searing off versus warming it up in your hand or maybe a composite warmer. I'm not sure, and I don't have a good answer for you.
Okay. Okay. How long have you been doing research with these bioceramic products?
I've been doing research with them for over 12 years now. I started when I was in residency, comparing compressive strengths of different bioceramic products, not just Avalon, but BC and ProRoot as well. And ever since then, we've done compressive strength, we've done animal studies, we've done in vivo studies, and I listed a few that we're working on right now, coming out of Texas A&M that should be published here in the next year or two, talking about kind of case series showing the success clinically.
Okay. I'm back. We're running out of time, and I needed
Yeah,
to thank
no
everyone
problem.
for your questions, but we've run out of time. And if we did not get to your question, we will answer it after the webinar via email. Shortly, we will send you a link to a replay of this presentation and instructions on how to access the CE quiz. Be sure to complete the free CE quiz associated with this webinar to receive your continuing education credit. I wanted to thank you all again for attending, and a special thank you to Dr. Ryan Walsh for a great presentation, and our sponsor for this webinar, Avalon Biomed. Thank you so much and have a great evening.
Thank you.